Thank you. I appreciate you having me here today, and you are my people. Not often do I get to speak to folks who love children as much as I do. I have 4 teenagers, so I don't necessarily love all of my own children every day, but you know, this too shall pass, and they'll be nice, mature adults one day. And off my payroll, so I'm looking forward to that. But it's good to see all of you. I am so glad to see so many friends. And then I just got a text, shout out to Madison County CAC watching in from Humboldt today. I didn't know that was a thing, but I just got a text that people are joining virtually, so hello to all my friends that are in virtual land too. Richard asked me to speak on sort of pre-COVID, during COVID, post-COVID, and Lord have mercy. Gosh, I'm glad that that's over. I don't know if it's over for us. I don't know if it's done with us, but we're done with it. We're just going to have to press forward. And I realize that creates a lot of anxiety for a lot of folks. But I made a list here of things that kind of happened during and things that we're working on after, particularly as it pertains to children and families, because I know that's near and dear to your heart. So, somebody lied to me a few years ago and told me being a commissioner would be really fun, and still trying to figure out who that was because I'm going to hold them accountable. But in all honesty, it has been a very fun and a very fulfilling role. The last couple of years have been exceedingly tough, and that's not just in state government, but that's been everywhere. But before COVID, as my kids call it, BC, and I thought they came up with that, and I thought it was kind of funny because obviously that felt like a very, very long time ago and before our world changed. But before COVID, we sort of spent the first year in the governor's administration creating a new strategic plan for the department, and it kind of had 2 big areas of focus. One is prevention, which is very classically public health, and the other one is access, which is very classically not public health. It's much more on the health care side. And let me give you a little insight. I came from the healthcare side of things, and for my entire career thought public health was just sort of one end of the spectrum of healthcare, sort of like when you weren't sick and all. It's very, very different. And it took me several months to sort of internalize that, but it's a different and distinct but very important role. That's a very classic, so prevention is a very classic thing for public health. So we were looking at the strategic plan and which one of these things need to come forward and which ones need to change? Many of them came forward, the things that you would expect, like smoking and obesity and hypertension and chronic disease and childhood immunizations and all of the things that public health classically does. But we're sort of looking at things like, well, what's really going to move the needle? And I think substance misuse was on the old plan, and clearly that's been a growing issue, although that landscape has changed, from prescription opioids now into more fentanyl and methamphetamine. But that was on our strategic plan. But one thing I felt very strongly about adding to our strategic plan was preventing and mitigating adverse childhood experiences. As you heard during my bio, I'm a child abuse pediatrician. And if you've never heard of that, that's okay. There's 6 of us in the state. But it is a subspecialty of pediatrics, just like pediatric gastroenterology or pediatric cardiology or whatever. And so now going on 16 years, I've been at Madison County Child Advocacy Center and still go most every Friday afternoon. Just saw patients this past week. And it's something that I see very, very frequently, and it usually manifests itself in, I come home and my husband, he's an OSHA guy, he's not medical and doesn't want to hear anything about it, particularly not in the field I work in. But what I tell him sometimes is if I were 8 years old and had to wake up every morning with the memory of what happened to me over the last several weeks or months or years, yeah, probably the first thing I would do is look for a shot of heroin as soon as I woke up. And that's if I were 8. Hell, that'd be if I were 38. And so it really sort of made it to be like, this is so important. We can't ignore this. We can't ignore the health impact of adverse childhood experiences. And this is a group that I don't have to explain the progression of how adverse childhood experiences end up in poor health and chronic disease. You already know that. A lot of people don't make that distinction. So for one thing, when we were setting our strategic plan, it was like, well, okay, well, with all these adult problems in Tennessee, why are you focusing on adverse childhood experiences? And then secondly, even if you can sort of understand that connection, well, what are you going to do about it, ma'am? And that's hard, because a lot of people do a 5-year strategic plan. I'll let you guess why we do a 4-year strategic plan in state government. Well, what are you going to do in 4 years or even in 8 years about adverse childhood experiences? And it's a really hard nut to crack, but it's a really important one. And so that is something that we felt strongly about in the department when we were setting our strategic plan about three plus years ago. The other portion is about access, and that's primarily coming from a place of, interestingly, you may not know about this of your home state, and because I've lived here my whole life and practiced medicine here my whole adult career, and I didn't know it, that the State Department of Health is the largest provider of primary care for the uninsured. It is the largest safety net provider. That's very unique. Other states do not do that. I can't find any other state doing it at scale. So it's kind of a dual role and makes for some interesting conversations. But that's the sort of the focus of our strategic plan. So that was all pre-pandemic. One kind of funny little thing, in December of 19, which was 3 months before our first case, I gave a speech one night at a chamber banquet about the 10 things that keep your state health official awake at night. Turns out pandemic was not on the list. It has done nothing but kept me awake for 2 years. I am sleeping now though, which is good. So we did have our first case almost 2 years ago to the date. It was March 4th, so it's been right at 2 years. And when everybody else went home, as they were supposed to, people in public health did not. And, it's kind of funny, when I talk to friends from other parts of the country or whatever, like, well, are you guys back in the office yet? I'm like, well, we never left. And our frontline employees never left. And in fact, most of them never got a holiday off. I think they got Christmas Day off that first year. But I know they worked on Christmas Eve because I worked with them. And I gave shots on Christmas Eve. I guess that would have been 20. Time means nothing now. Is it just me? Or have you lost all concept of time? I've lost all concept of time since this happened. So, we've got these frontline employees that never left and were there to fulfill our mission. And when I was talking about our strategic plan, we did do kind of a relook at our mission statement. And our mission statement is to improve and protect, promote, and improve the health and prosperity of those in Tennessee. Well, you sort of kind of figure out about the health thing. Like, wait, why are you talking about prosperity? Because isn't that sort of an economic thing? What do you, Dr. Piercy, have to do with prosperity? And if you look pretty closely, and again, here's a group, that's why I love speaking to you guys, because I don't have to explain all this. You already know about the link between chronic disease and early mortality and its relationship to income. And what's the number one driver of income? College and career readiness. What's the number one driver of that? Third grade reading level. What's the number one driver of that? Early childhood literacy. So it does really all go back to kids, right? And I'm not just saying that because I'm a pediatrician. But as we're sort of fighting this pandemic, we're trying to keep people healthy, but we're also sort of trying to keep them prosperous as well, which takes on a whole new meaning in the environment that we lived in. One of our primary areas of focus during the pandemic, and I think you probably saw it, I hope you saw it, was our focus on vulnerable populations. And that means a lot of different things. First and foremost, probably the earliest on was the long-term care population, the nursing home population. everybody understands how badly that industry was ravaged those first few months. And so that was an area of focus for us. The incarcerated and those experiencing homelessness, those were foci of our work then, because those were the people who might fall through the cracks. Well, who else might fall through the cracks? Those receiving services from Children's Special Services and families with special needs children or children with disabilities. We did outreach and made phone calls to every single one of the thousands of families enrolled in that. And so that was something that from a child and family standpoint that I thought we did well during the pandemic. I am not here to tell you we did it all right. In fact, I'm not even here to tell you what right is. Like, there were some things that were better or worse, but do you remember that word they kept using at the beginning? Novel? A novel coronavirus? That means it's new. And I may or may not have made a couple of snarky comments to the media like, oh, I'm sorry, I didn't see that in the playbook. And it's kind of snarky, but it's sort of like, dude, we're making this up as we go. Don't be acting like there is a wrong way or a right way. And this whole notion of follow the science. Of course I believe that. I'm a lifelong scientist. But if we're all being academically honest, there's not a lot of science about this. You know, when have we ever studied at scale the effect of masking children in school? Never. Now, we know about mask and surgery, and we know that works. And I'm not here to say one way or the other about masking children in school. There are some logical arguments to say, oh, that sounds like a bad idea. There are some scientific arguments to say, yeah, that reduces spread. But when this whole notion of follow the science, well, that works fine when there's well-established science, but with something like this, it's kind of difficult. But one thing we did know is that there were very clearly some populations that were more vulnerable than others. And so one thing we tried to do at the department is focus on those and really bring, one of the things that all state departments of health do very well is data. We are the repository of data for the state, whether it be vital records or hospital discharges and everything in between. So we had some of the most robust reporting of the impact to pregnant women and children in the nation. And there's one thing, oh, Lordy mercy, I spent more time with that governor than I did with my spouse the first year. And that's no exaggeration. The two of them joked about it. But one of the things Governor always asked me, or at least in kind of when everything was hot and heavy, is what are other states doing? It's not that we want to be like other states or we're trying to prove that we're better than other states, but it's like, hey, we're all sort of trying to figure this out together. And when the impact to children became pretty widely known, particularly as it pertains to MISC, the multi-system inflammatory condition that is very rare but is very serious in some children, we got to looking at that and hardly any state was doing good reporting on that. And we could barely find any state that was reporting on cases in pregnant women, and particularly pregnant women of minority descent, so specifically Hispanic ethnicity. Because you remember the time, I think it was May, June, July of that first year, when the meatpacking plants some of the farms, particularly in East Tennessee, had really, really high levels of outbreaks in the Hispanic population. That is a very young, in our state, that's a young population. So a lot of working mothers and young mothers of Hispanic descent. And so we really thought it was important to call attention to the rates of disease, not only in the minority population, but specifically in the pregnant population and amongst pregnant minorities. The other thing that, because of those same vulnerabilities, is we had a really big focus on messaging, public messaging, to those very targeted populations. It'd probably be the only time in my career, and I'll take credit for it, it's not my work, we actually got an Emmy nomination for one of our commercials related to, I think it was about testing in pregnancy. And if you're pregnant, if you're not feeling well, you remember early on when people were scared to go to the hospital because they were scared that they would get infected if they went there. Well, we had a lot of pregnant moms who had some symptoms of preterm labor or were sick, but didn't go in and avoided care because they were worried they would catch COVID or get something worse if they went. And so some of those public messaging campaigns, we did not win the Emmy, but as they say, it was an honor to be nominated. I was like, really? Wow, that's cool. It had nothing to do with me. I just signed the paper. So, I think we, in addition to sort of our baseline focus on families and children, we tried to make a concerted effort during the pandemic to focus on and highlight those pieces of work that were so important to these special populations. So where does that leave us going forward? Well, we get to go back to our strategic plan. And I just started a little video series for our employees last week about, hey, let me remind you of all the components of our strategic plan. Because two and a half years ago, just about every one of the 4,300 employees could just spit it out. And we've all sort of, as they say, slept since then. We've all had other things on our minds since then. And so sort of doubling down, refocusing our efforts on those two big areas of focus, but particularly on the prevention side that I was mentioning. Another thing that we are going to do, and we're going to be doing for quite some time, it's not unique to us, it's addressing the health debt that was created during this pandemic. One of the things that really, really bugs me and worries me is the significant drop of routine childhood immunizations. And you would think, and it would be normal for you to think kind of naturally, that there's been this big shift or increase in vaccine hesitancy since the pandemic. Okay, so we all get it. There was a lot of vaccine hesitancy related to the COVID vaccine. All right, then we can talk for an hour about why that is. And then you see this big drop in routine childhood immunizations, and you're like, holy smokes, now nobody wants any vaccine. It's actually not like that. It's not. We don't hear a lot of, or no more than normal, vaccine hesitancy for routine childhood immunizations. It was that a lot of families with young children delayed care, delayed immunizations, and then now are playing catch up. And some of them don't really understand, like, it's okay to catch up, and you don't skip those. It's not like when you miss your blood pressure medicine, skip it and take it the next day. No, you just got to start over. And so one of the things you can do is help us get the word out to families that you're working with. First of all, it's totally normal. If you got behind on immunizations during, it's those first 5 years. If your kid got behind on immunizations, you're not a bad parent. Nobody's going to judge you. It's not a big deal. It happens to a lot of people. Just get on back in and get started now. So that's one thing you can help us with. Another thing that kind of pertains to the health debt from the pandemic is a lot of delayed care in adults. And so I mentioned a minute ago where pregnant women were avoiding going to the hospital. Well, it wasn't just pregnant women. There were a lot of people who delayed care or avoided care for a lot of different reasons. They were scared they were going to get sick, or they thought, you see on the news, the hospitals are so full. Well, it's just a little chest pain. I don't really want to wait 7.5 hours in the ER. It'll be fine. In a lot of cases, it wasn't fine. We put out I told you the state's real big on data, and we put out our excess death report, I guess it was probably in August or September. We put it out every year. It's probably a report you've never heard of, but that's what we're good at, putting out reports. And this is a report that every year details, because we do have vital records, and so all the births and deaths and all that, like, what are people in Tennessee dying from? And for a bazillion years, we've had about the same number of deaths. And I don't know what the exact number is, but I'm going to say plus or minus 85,000. Could be a little more, could be a little less. We have about 80 or 85,000 deaths every year, pretty much every year, and it grows as the population grows, but it stays pretty steady. And the causes of death are all pretty common, and same from year to year. The things you would predict. Heart attacks, cancer, stroke, COPD, car wrecks, gunshot wounds is the same top 8 or 10 list every year. But last year, we had 13,000 excess deaths above what we normally do. And only 6,500 of those were attributed to COVID. So that means 6,500 people, maybe, if my number of 85,000 is close, maybe almost 10% increase of people who died last year. Well, this would have been in 2020 because we reported it in 21, who died in 2020 that normally would not have died, that did not die of COVID or anything COVID related. So they're dying of heart attacks and they're dying of cancer. And it's all, we think a lot of it is because of this delayed or avoided care. We're probably going to see it get worse before it gets better because there were a whole bunch of people who had COVID and have these long-term effects, we call them comorbidities, that they wouldn't have had otherwise. So whether that's, they had a stroke or they had some type of heart abnormality, which is relatively common after COVID, we're going to see that continue. And then the other thing we're going to see continue sort of in the long run is people who put off screening. So, if you're supposed to have your colonoscopy and you didn't, maybe you were already a year or two past your 5-year cycle and like, oh, I missed it last year. Well, I'll just get another one in 2 or 3 years. I mean, that's the difference in a benign polyp and full-blown colon cancer, that delay in care. So we're going to be digging out of that debt, that health debt from the pandemic for quite some time. But not all is lost. We've learned some things and had some good things come about. One of them is just incorporating cool things that we probably would have never done, or it would have taken us a very long time to do had we not sort of been forced to do it. Everybody in this room has now had some experience with some type of remote work, right? And state government is kind of a very traditional, bureaucratic, slow-moving, nobody's ever accused any state government of being highly innovative. Okay, that's just the nature of the beast. We like to think of ourselves as that, and we think we are individually, but generally speaking, state governments are kind of stagnant. And so even though there were a good number of, we call it AWS, alternative workspace or worksite, I can't remember, but even though we had some efforts to do remote work, it was like, oh, well, you need to come in the office. Well, we suddenly realized, I can only speak for the Department of Health, but I know many of the other state agencies feel the same way. I told you, one of the things that health departments do is data. Well, you don't have to be in person to do data anymore because we all have it on our computers. And so we've been able to send a large percentage of our workforce home, at least for most of the time, if not all of the time, because we have a lot of data processors that can work from home. So that was a good thing that came about. It helps with recruitment. It helps with retention, particularly when you're state government and you can't pay like the private sector does. And so that's been a win for us. As it pertains to our patients, we've had wins with telehealth. And whereas telehealth has kind of been a thing in medical settings for, 15 or 20 years now. It's not new or novel. For state departments of health, and particularly ours, which I told you provides a lot of primary care for the uninsured, we can't do that. Our patient population can't support that because our patient population is low income, they're uninsured, they have trouble with transportation, we were wrong about that. They can do telehealth just like anybody else. And in fact, it probably serves them better because they don't have to get a ride and they don't have to be there at any certain time. So it might actually improve compliance. Well, it took a pandemic to figure that out, but we'll do better going forward on that. Something else that was one of those things that kind of had mixed feelings, but turned out more positive than negative, is the WIC flexibility. So, instead of having to come to the health department every month to get your money loaded on your WIC card, well, you just do all that remotely now. Now, I will tell you, I have mixed feelings. As a pediatrician, particularly a child abuse pediatrician, I have mixed feelings about that because there are some kids that you need to lay eyes on. And there are some kids that you really don't know until you see them that they're malnourished or they have a bruise across their face. And so that's one of those things that, and like with any good thing, if you take it too far, it's probably not great. So, we kind of overshot in that and bringing it back. And I don't know where, and most of that's dictated federally, it's not my decision, but I think maybe a good point is, I'm making this up, but if the feds want to listen, I think it's a good idea. Okay, you don't have to come in every month, but maybe you come in once a quarter, or maybe you come in twice a year in person. something that bridges that gap. But those are the kind of things that increase compliance. What is the number one way, evidence-based, to address childhood obesity? WIC participation. So if I can increase WIC participation by making it more convenient, well, that's a win, and we should do that. But one of the things that, and I'll close with this because I stand up here and talk to y'all all day. One of the things that we learned that particularly was applicable to children is just kind of a global lesson that we learned. Physical health is not the only consideration. And you remember back, particularly in the first summer we did this, when we had to decide to go back to school in August of 2020, I guess it was, there was a pretty strong narrative that being at home was the safest place for children. I know you guys share the same mentality that I do. Home is not the safest place for some children. And I told you I still see patients every week, and I can't tell you how many, and I've always seen about 70% of my patient population is child sexual abuse, and that hasn't changed percentage-wise, but I am starting to hear more and more, well, mom had to go to work, and so we left kid with so-and-so, or we left kid alone. And that's not the safest place for kids. Many kids are not nutritionally safe at home. They need that interaction. And all of the things with isolation and mental health and kids, one thing that I hope you take away from the pandemic, because we certainly have, is you have to treat the whole person. And physical health is not the only consideration. It's very, very important, but it's not the only thing. So as we go forward, my hope for you and my hope for myself and my agency is that we treat the whole child and the whole family and not just one aspect. Please let me thank you so much for what you're doing. I don't even want a round of applause for myself. I want it for you and the work you're doing. And I am so glad to see so many of you here in person. If I can ever do anything to help you, please call. Thanks.